The title of the study is Improving Outcomes of Renal Transplant Recipients with Behavioral Adherence Contracts, a Randomized Controlled Trial. Dr. Koop put it quite elegantly when he stated, drugs work in only those that take them. Surprisingly, the act of taking medication results in challenges for a number of individuals. The issue of non-adherence can result from the combination of a number of factors: forgetfulness, cost, pill burden, adverse effects, education, and others. Adherence is not a new topic. With the utilization of highly active antiretroviral therapy in the 1990s, the correlation between poor adherence and viral resistance was clear, and a surge of adherence articles have been published among numerous disease states. Nearly 31% of prescriptions are not filled the first time. This means that patients drop the prescription off at the pharmacy and don't take it home, or they never reach the pharmacy. Today, medication non-adherence accounts for greater than $300 billion a year in the U.S. alone. 15% of hospital visits due to medication non-adherence, which accounts for approximately $47 billion a year in the U.S. 60% of patients are unable to identify their medications. Multiple generics and switching of generics throughout the year can also compound this problem. 67% of patients have reported the missing doses at times. The biggest dip in medication non-adherence occurs after the first fill, month 3, and again at month 6, with approximately 40% of patients no longer taking the medication. And within the percentage of patients that take their medications, there are 22% that take less than is prescribed. So according to this information, only 25% of those who are prescribed medication actually take it like they should. The impact of medication non-adherence can result in a number of factors: resistance to the medication, such as antibiotics, and even some chemotherapy agents, such as those treating chronic myeloid leukemia. Suboptimal responses to therapy. Non-adherence can decrease the drug exposure and result in issues such as higher blood pressure when prescribed an antihypertensive. 1 in 8 patients stop taking medication prescribed after a heart attack, which can result in disease progression and potentially death. In a review of over 12,000 Medicare claims for renal transplant recipients, patients with higher medication possession ratios, the number of fills over a defined time period, have an overall reduction in medical costs over a 3-year period, $31,000 versus $58,000. This is yet another example of lower adherence rates causing a decrease in patient outcomes. Even in clinical trials, where patients are observed for outcomes and adverse drug events, the variability of adherence ranges from 23% to 91%. Some benchmark adherence rates demonstrate that across numerous disease states, the rate of non-adherence averages approximately 50% by month 6. For patients that have received a kidney transplant, non-adherence approaches 36%. Avella had the opportunity to work with the University of Arizona on an NIH-funded adherence trial in renal transplant recipient patients. The study was led by the principal investigator Marie Chisholm Burns from the University of Arizona and utilized patients from Avella Specialty Pharmacy. Immunosuppressant therapy, or IST, is required to prevent the host immune system from attacking and subsequently rejecting the donated organ. Non-adherent transplant recipients to prescribed medical regimens has been identified as a major cause of allograft failure. IST non-adherence is estimated to occur in approximately 36% of renal allograft recipients and may be a component of allograft loss in approximately 36% of patients. IST non-adherence is associated with an increased incidence of rejection, acute and chronic. Non-adherence also results in decreased renal allograft survival, which requires costly medical interventions and an increase in morbidity and mortality. Many patients don't understand their medication therapy or why they are taking it. In a study of patient interpretation of written prescription instructions, researchers found that 25% of subjects interpreted the phrase every 6 hours as meaning 3 times a day. Behavioral contracting is utilized to influence patient behavior and introduce strategies to engage a patient to become more active in their treatment. The objectives of the study were to assess the effects of a behavioral contract on IST adherence and to determine the effects of the intervention on direct healthcare utilization and costs. Randomization was by number sequence in a 1-to-1 block stratification. Study participants, the coordinator, and investigators were not blinded. The study pharmacist was blinded to the control group patients. Patients that provided written consent completed a health contract which reviewed the patient's goal to obtain the highest adherence rate with their IST therapy. The intervention group met with the study pharmacist by phone or in person to review the health contract at months 0, 3, 6, and 9 of the study. At the 12-month post-enrollment meeting, the study pharmacist and the RTR terminated the contract. This slide demonstrates the number of patients that were looked at to enroll in the study. 150 patients met criteria, 76 in the intervention group and 74 in the control group. 15 patients dropped out. Patients recruited from the renal transplant recipient population were managed by Avella. A list of eligible patients were initially contacted by telephone or during pharmacy visits. The description of the study and permission for the study coordinator to contact them was obtained. If permission was granted, the study coordinator provided further details and sent the patient a study packet that included a consent form. The intervention and control groups had equal characteristics. During the early months of the study period, a toolbox of standardized solutions to adherence barriers was developed as an aid to the contracting process. Some of the items utilized were pill boxes, blister pack with cards labeled AM and PM, cell phone alarms, talking clocks, regular alarm clocks, sticky notes, refill reminders from Avella, wristband reminders, and the utilization of MyMedScheduler.com. MyMedSchedule provides a free text message program at specific times. Email refill reminders were also part of the toolbox, key fobs, lids that beeped and blinked, keeping the medications in sight, taking the medication the same time each day, and finding a routine and sticking to it. The medication possession ratio is calculated as follows: 1 minus the days between refills minus the total day supply divided by the days between refills. In addition, pill counts were also performed each 3-month period by the study coordinator. At baseline, it was noted that the medication possession rate was 83%. Adherence rates were highest at month 9, with the intervention group reaching 91% versus 81% in the control group. At month 12, the adherence rates were 89% in the intervention group and 79% in the control group. 40% of the study patients reported at least one hospitalization in the study period of January 2010 through September of 2011. Of the 40% of patients, 57.3% were in the control group and 23.9% were in the intervention group. The intervention group increased the probability by 78% of not being hospitalized. Using the Medicare Expenditure Panel survey data, the median number of days in a hospital per patient is 0.33 days per month, with the average cost of $2,000 a day. In a cost projection sub-analysis out of 100 patients who are hospitalized, approximately 29.09 patients would receive the intervention and 70.91 would not. Based on the Medicare expenditure data, the difference between these two groups is a savings of $27,852 per month in healthcare costs. Overall, this study demonstrated the ability of a patient contract and pharmacist interventions to improve renal transplant recipients' medication compliance and adherence, as well as decrease healthcare costs. A vital component to graft survival is immunosuppressant therapy adherence, and healthcare providers are continuing to search for a validated method to improve patient outcomes and decrease healthcare costs. The utilization of a behavioral contract and clinical pharmacist intervention demonstrated improved adherence rates 12 months from the baseline measurement. In summary, Avella would like to thank all the patients and their families for participating in the study. Avella continues to explore opportunities to improve patient outcomes to therapies such as clinical trials, bi-directional text message programs, glow caps, pharmacist interventions, and letter campaigns. We believe that publishing a randomized trial provides the evidence-based interventions that healthcare providers are searching for. Avella encourages patients and providers to review our website or contact us for ways we can improve patient outcomes.